Question if you're a third year MBBS student or even if you're a second year MBBS student, and this mind map will cover all the important details and will help you to answer the questions. So let's dive into it. The introduction. The typhoid fever is a result of systemic infection by Salmonella typhi, and the term enteric fever includes both typhoid and paratyphoid fevers. The problem statement: globally there are 21 million per year cases which are estimated, and deaths are around 216,000 to 600,000 per year. In India, the cases are around 1.53 million, deaths 361, and typhoid is endemic in India. The agent factors. So under this you have to write about the agent, that is Salmonella typhi. You should also write about the reservoir of infection and the source of infection. So the agent is Salmonella typhi, which is three main antigens, which is O antigen, H antigen and VI antigen. It is readily killed by drying, pasteurization and disinfection. The reservoir of infection is the cases. So it is infectious as long as the bacilli is appearing in the urine and the stool. The carriers can be temporary carriers or chronic carriers. So temporary carriers are incubatory. They are carriers in the incubatory period or in the convalescent period, which means up to 6 to 8 weeks. They excrete the bacilli. So chronic carriers are excreting the bacilli for greater than 1 year after the clinical attack, and so chronic carrier state develops in about 2 to 5% of the cases, and the types are continuous, intermittent, fecal and urinary carriers. In most cases, bacilli will persist in the gallbladder and the biliary tract, and they may excrete the bacilli for up to 50 years. The source of infection. The primary source of infection is feces and urine of the cases and of the carriers, and secondary source of infection is the contaminated water, food, fingers and flies. You can remember that by the sanitation barrier. So far we discussed the agent factors, the host factors. Age, all ages are susceptible, and the peak incidence is 5 to 19 years of age group. And in sex, there is a sex predilection, that is in cases males are more predominant, and in carriers females are more predominant. Immunity. The natural typhoid fever does not confer reliable immunity. Second attacks may occur when challenged with a large dose. And antibodies to O antigen is higher in patient with disease, and antibodies to H antigen is higher in patient to immunized persons. The factors which confer immunity are local intestinal immunity and gastric acidity. The environment factors are season. It is reported year round, and peak incidence is from July to September. Food. Bacilli may survive in water for 2 to 7 days, and ice cream and ice for 1 month. Soil. The bacilli may survive in the soil irrigated with sewage in winter up to 70 days and summer up to 35 days. And human habits in open air, defecation, micturition and poor personal hygiene. These are the environmental factors. Prevention and control. So the prevention is by immunization. So VI polysaccharide vaccine. We're going to look at the route, the dose, the schedule, the age and the immunity. The route is intramuscular or subcutaneous. The dose, it is a single dose, 25 microgram of antigen per dose. That need not be remembered, just remember it is a single dose. The schedule, it is a single dose and revaccination is every 3 years. Age greater than 2 years old, and immunity begins 7 days after vaccination. This is Typhoid 21A vaccine. The type, it is a live attenuated vaccine, and preparation, it is capsules. The oral route is the route of administration. Okay, now the schedule. The schedule, it is given on days 1, 3 and 5, and repeat the series within 3 years in endemic areas. The age, it is given in greater than 5 years old. Immunity, it is achieved after 7 days after the last dose, just like in VI polysaccharide vaccine. Precautions. You have to stop if you're giving proguanil or antibacterial drugs, so because of the interaction. And contraindication is immunodeficiency state, which can be acquired or congenital. Now how can we control this? So the control of reservoir, the control of the cases is by early diagnosis. You can do it by culture, blood and stools, and by notification where necessary. Isolation till 3 bacteriologically negative stool and urine reports are obtained on 3 separate days. Okay, now treatment is fluoroquinolones. These are the first line drugs, fluoroquinolones, and disinfection is done with 5% cresol greater than equal to 2 hours. Stools and urine are disinfected and follow-up has to be done. So examination of stool and urine has to be done. Now carriers, they are identified by serological methods in culture. They are treated with ampicillin or amoxicillin 4 to 6 gram per day and probenecid 2 gram per day, both for 6 weeks. Now surgery, cholecystectomy is the ideal treatment with ampicillin therapy, and nephrectomy can be done in refractory cases with one damaged kidney. So surveillance of carriers has to be also done, and health education is important. Hand washing with soap and water after defecation and micturition and before preparing food. This is also important. Control of sanitation, that is safe drinking water, improvement in sanitation and promotion of food hygiene should also be done to control the disease. That is the prevention and control of typhoid. On to the lab diagnosis. So there is microbiological, that is blood culture, serological, that is Vidal test with false negative rate up to 30%, and newer diagnostic tests. So microbiological, blood culture, serological, Vidal test, and new diagnostic tests, that is Typhoid and Typhoid-M. So Typhoid detects both IgM and IgG. Typhoid-M detects only IgM antibodies. What are the clinical features? So in fetus, in onset, prodromal stage is there, which presents with malaise, headache, sore throat and cough, and then fever, which is a peculiar kind of fever, that is step ladder pattern. Usually there is tachycardia. Here it is bradycardia and diachrotic pulse. And GIT, there is pea soup diarrhea, abdominal distension. And rash is rose spots appear during second week of the disease, and the rash is found on the trunk. Complications are hemorrhage and perforation. These are intestinal complications. And do subscribe if you've not yet done it, because a lot of effort goes into these videos. Thank you.